Hello, my name is Dr. Suzanne Barron from Leahy Hospital and Medical Center. I'm the deputy editor of SCAI. I'm here with Dr. Yasin Hussain from Yale School of Medicine in New Haven, Connecticut, and he's the primary author on the sex-based outcomes of coronary intravascular lithotripsy, which was a recently accepted paper at SCAI. Joining us for this conversation are our panelists, Dr. Donna Abbott from Brown University in Rhode Island, and Dr. Akiko Maehara from Columbia University Irving Medical Center in New York. Welcome, everyone. So I'm going to turn this over to you, Dr. Hussain, to let you talk to us a little bit about what you did and what you found.
All right. So I'd like to start off by thanking SCAI for the opportunity, and it's a great privilege to be presenting this data to this great panel of experts. I'll be discussing our findings on sex-specific characteristics and outcomes in coronary intravascular lithotripsy, which is a patient-level analysis of all 4 Disrupt CAD trials. I have no conflicts of interest specific to this talk. Starting off, we know that severe and moderate calcification is associated with worse outcomes in PCI in both men and women. And when we look specifically at women with moderate to severe calcifications compared to women with low or no calcification who undergo stent implantation, they continue to have poor outcomes even at long-term follow-up. And the treatment of severe calcification remains a major challenge in PCI. Women specifically who undergo arthroablative technologies or arthroablative strategies to deal with severe calcification tend to have a higher procedural complication rate than men. With that background in mind, we wanted to look specifically at intravascular lithotripsy, which is a balloon-based technology for treating calcified lesions. It works by emitting acoustic pressure waves to crack the calcium in situ, and that improves vessel compliance and allowing for stent implantation. The safety and efficacy of this technology in women has not really been studied prior to this, and given the high rate of procedural complications with arthroablative technologies, we thought that it was really imperative to find a technology that would be safe in this patient population. So in this pooled patient level analysis of all 4 Disrupt CAD trials, all 4 registries, we evaluated IVL, and this was a 30-day safety and procedural efficacy assessment, which included 628 patients, 23% of whom were women. Some baseline patient characteristics: women were older and had higher amount of risk factors for CAD, excluding smoking. Angiographically, women had smaller vessel diameters, which was expected. And I think it's most important to highlight from this slide that angiographically, the population had severe calcification, 95.8% and 97.3% in women and men respectively, and that was not really statistically significant. So this patient population had severe calcification. It was generally pretty diffuse disease. Regards to the interventions, pre-IVL dilation was used in less than 50% and was used equivalently in both sexes, and all patients almost in the population had successful stent delivery. The main takeaway from this slide is, again, the severity of calcification, the diffuse disease in this patient population. Our primary safety endpoint was 30-day major adverse cardiovascular events, which was a composite of cardiac death, myocardial infarction, and target vessel revascularization. 30-day MACE occurred in 8.3% in women, 7.1% in men, without any statistically significant difference, and was primarily driven by non-Q wave MIs. Again, were kind of similar percentages in men and women and not statistically significant. The primary efficacy endpoint was procedural success, which was defined as successful stent delivery with less than 30% residual stenosis without in-hospital MACE. And again, we see 91.7% success in women and 92.6% success in men without any significant difference. One of our significant findings in this patient population was the procedural complication rates. So the procedural complication rates we see here is a composite of severe dissections, which were dissection type D to F, perforations, abrupt closures, slow or no reflow. And we see that there's no statistically significant difference. The rates are very low, numerically a little bit lower in women. And this is really the first time in a population with such severe disease, such severe calcification, that we show women and men having similar complication rates after this type of intervention. This slide is just to kind of compare IVL with arthroablative technologies. This table represents data from 3 different populations. Again, we don't really have any randomized data comparing these 3 technologies, but it does highlight from what we know now, and the orbital atherectomy data comes from the ORBIT-2 sex analysis, sub-analysis, and the rotational atherectomy data comes from a single center retrospective study. But this does highlight to us that women specifically getting IVL do have a lower rate of procedural complications. And then finally, what this means for clinical implications, again, we've shown that the use of IVL for lesion preparation of severely calcified lesions is safe and effective in women with very low rates of procedural complications, and it should be considered really a safe option for treating calcified coronary lesions in women. Thank you so much. I'd like to thank Dr. Lansky, specifically my mentor, and everyone else who helped with this manuscript.
Well, congratulations on a really thoughtfully and well done analysis that I think really addresses an incredibly important subject for our patient population. I think I'm going to throw something out to our panel right now, and I guess I'll start with you, Dr. Abbott. How, looking at these results, how are you thinking that you might apply them to your everyday practice in the cath lab? You've got a patient that comes in. It's a woman. She's got a severely calcified lesion. Does this affect what your strategies are in the lab?
Thanks, Suzanne. I'm terrific presentation. The results are really impressive. I just want to start just to talk a little bit about the baseline characteristics of this population, which is a little bit different from your typical coronary disease population. So when you're considering applying this, women were older, as is typically seen, but the age difference was, less in this study than previous studies, and these patients in general were in their 70s. And in terms of baseline risk factors in coronary disease extent, women were more similar to men than in prior studies. And so again, this is a patient population which has a high burden of disease. Just to start off, it is impressive that angiographically the calcium was severe, but one limitation of the analysis that I'm sure will be discussed is that the angiography only tells you so much. So while I am impressed with the safety in women, I don't think this study helps us to differentiate in which women with calcified disease is this device, when would you choose this device compared to other atheroablative devices? Clearly, the atheroablative devices have higher complication rates in general, but it is unlikely this will replace them, and there's probably some good combination of use or additional things we can learn from examining the calcium a little closer in terms of which devices to choose. I did notice procedural wise, and we didn't have time to review all of the information here, that these lesions were on average maybe about 4 centimeters, and most patients only required 1 catheter, but the mean catheter use was 1.2 in women and 1.4 in men, maybe because their lesions were slightly longer or they didn't yield as well and the operators felt more pulses of energy were required. Another interesting thing was that post-dilation was pretty low, I want to say under 20%. And in my practice, I would commonly, after using IVL, choose an appropriately sized non-compliant balloon to do a high pressure inflation prior to stent placement to really make sure you've modified the vessel the way you want it to make sure the stent is expanded well. So, and lastly, this is really great. And I'd love to see the later data to see whether this is going to translate into really low restenosis rates, which would be terrific.
Absolutely agree with everything that you said, Dr. Abbott. I think especially when we think about the whole spectrum of treating patients with, optimal PCI techniques, bringing up what you said, talking about post-dilation. You didn't mention it, but you alluded to the idea of needing to image appropriately, to kind of really get a sense of how calcified these lesions are, how long they are. I think as we go into the next phase of interventional cardiology, it really is going to come down to this very precision, type of PCI with imaging and using the right devices for the individual patient. Dr. Maehara, your thoughts on the findings and what Dr. Abbott has offered.
Yeah, by the way, I reviewed the OCT sub-study in this study, so I know how it looks like by OCT. It's very calcified cohort. I know that's really confirmed by OCT. And in terms of the calcification, can we do better in terms of the choice of the device by imaging? Is actually not too much, but at least what we can tell is when we put the OCT or IVAS and then to see what's the location of the wire bias. And if that is really well opposed to the calcified segment, that's good. But if that is located in the non-calcified segment, actually this is dangerous. So that we can tell better using the intravascular imaging. And also, sometimes even angiographically looks very severe calcium, but it is majority was deep calcium. And then when we do the intravascular imaging, actually we found that's actually not inhibit stent expansion. And sometimes we can downgrade of the device to use. That's the help for the intravascular imaging. But in terms of the woman specific, is what is really, really important is really the vessel size. And because we are especially this cohort, we are treating the very severe calcified lesion. Already, we know they are really difficult to expand. So once we start from the small vessel size, we have less capacity to expand more. So we have more burden to make better compared to the mom. So I think that really the benefit to do the intravascular imaging, especially the woman, is really we can maximize what the size of the balloon and stent to make as much as better. But already start with the small vessel size compared to the man, and woman has really more aggressive to make it as much as possible. So that's a very basic difference compared to the woman and man and in relation to the intravascular imaging.
That's an excellent point. I think it also brings up exactly what you guys have both said, which is, how do these results play out in the long term? Does it translate to better outcomes, lower restenosis rates, even despite the fact that, women do have smaller vessels, and thus are going to be, smaller stents, going to be more inclined to develop ISR. So I guess I'll ask you, Dr. Hussain, are you guys planning any longer term analyses looking at sex-specific differences in this cohort?
Yeah, I think it's going to be a very valuable question to answer. Unfortunately, not all of the Disrupt trials go on to cover more than 30 days. But we have at least Disrupt 3, which went up to a year. And the data that was presented didn't really show that there were any sex differences in the long term. So at least from that population, we think the results will be promising. Again, I think the main key is going to be something that will give us a better answer of which technology really to use and whether IVL is really better in women or not. Because I think with sex comparisons, we're not necessarily going to see a benefit. It's just going to be kind of a similar rate of restenosis, I think, in men and women.
Which I think also leads into sort of my next question is we know that women are consistently underrepresented in clinical trials, and here as well are representing about 25%, I think you said, of the patients in this study. I think you're right. To get a really good answer, we're going to really need to look at a broader population, and also, that's going to require us to really work to make sure our women are represented in clinical trials. So I'd like to ask, I'll throw this out to anyone on the panel, and if nobody picks up, I'll pick on someone. You have unlimited funds. What is the next study that we should do to try to clarify some of the questions that have been brought up by this analysis and in this discussion?
Yeah, that's a really difficult trial. I mean, we have, 3 excellent devices available in most labs. I'm not saying throughout the world, but in the United States, the orbital, the rotational, and now IVL, and they're not all completely interchangeable. I suspect you could design a trial that would enroll patients who are only suitable to have all of them and then randomize, but that would be ridiculously massive and probably wouldn't help us in the long run. So I think just building data sets of imaging and outcomes with different devices, and maybe using AI to give us a hint as to which devices perform. At the end of the day, I think if you use each device with good technique, you will get a good outcome. And the nice thing about IVL is there's less risk aversion. People aren't as afraid to use it and to be aggressive with it. There's not like a level of aggression or time or patience you need the same as the other devices. The learning curve is shorter, so I see greater adoption of IVL, but in terms of a trial, I don't think we should continue to, try with or without plaque modification trial. I don't really think one device versus another device trial, but really trying to fine tune optimal ways to fully prepare vessels with potentially combinations of devices if needed.
Yeah, I don't think I have I don't have the idea to make the good trial, but I would emphasize one thing, meaning like when I look into the intravascular imaging in terms of the calcification, the one place which is very unique for the woman is actually osteal region. When you look into the right coronary osteum or left coronary osteum, we see more calcified nodule and more often seen in the woman compared to the men. Like when we look into the regular epicardial artery, the prevalence is quite similar compared to the any place. But when we go to the osteal region, always woman is much more than regular prevalence. So, and then osteal right coronary artery is very frequent having the issue, and also a lot of calcified nodule compared to other place. So something unique for the woman. So that's, I'm not saying a trial, but we have to think about a little bit more, something specific for the woman. In my mind, the osteum is very important for the woman to make it better.
I think you're right. Osteal lesions are they're a whole nother bag of issues there, and certainly something that we probably do need to study more. Well, I just want to thank Dr. Hussain for presenting, again, a very beautifully and well done analysis on a very important topic. I want to thank my panel for being here and engaging in a great discussion, and we hope you'll join us again in the future for more conversations with the JSCAI staff. Thank you very much.